So I'm chairing today. My name is Egbert Sondorp. I'm the chair of the Thematic Working Group on Health Systems in Fragile and Conflict-Affected Settings, which is part of Health Systems Global. And let me just briefly introduce this Thematic Working Group. It's an active group of more than 2,000 members, and we try to connect and engage researchers, policymakers, donors, practitioners, and quite a few others to advance the field of health systems and policy research in fragile and conflict settings. So we try to do this through a number of means. One of them is to run a series of webinars, which we have now given the term talking points. Yes, next, please. So these are some ways to connect to us or to learn more about us. On the Health Systems Global website, there is a dedicated page. You can learn more about how we are organized. And that's also where you can join. We have several ways of how you can join the group, primarily through LinkedIn, but there's also a Gmail group email, Google Groups, through which you could connect. It should be pretty straightforward once you start looking for it. Yes, please. So today we run this webinar in conjunction with Rebuild for Resilience, that's on the occasion. We always work closely together with Rebuild in the past, and these days Rebuild for Resilience, and that's a FCDO-funded consortium which is researching health systems resilience in fragile and shock-prone settings. They are active on quite a few fora and occasions, and in particular they have a close contact with programs in Lebanon, Myanmar, Nepal, and Sierra Leone, Yemen, and Afghanistan. And today in particular we are joined by Wissam Mansour, who we will see soon, and Fouad, who you will see him a bit later in the program. Again, it's easy to find more information through this thing on the right side and also through the website. So can I have the next slide, please? So let me briefly introduce the agenda, which you may already have seen before signing up, but we have an introduction by Dr. Wissam Mansour, who's based in Liverpool, and she will talk about Beyond Equity, Unpacking the Health Justice in Health Policy and Systems. So that's the general base on which we hope to also discuss the case studies. And the case studies will come from Yemen. I will introduce it a bit later when we are there, from Sudan and from Myanmar. And once we have those case studies, which we hope to take around 10 minutes each, then we'll follow up on a panel discussion where we in particular have Dr. Mohammed Al-Hadi and Professor Fouad to give comments to what they have been hearing, but it also will be the time that we will try to answer any questions you may have. So please, if you have questions, post them in the Q&A box. I'm sure you're all familiar how to do this these days, and we'll try to respond to them. Next, please. So I'm very pleased to introduce Dr. Wissam Mansour. She will introduce our session, and she is a postdoctoral research associate at the Liverpool School of Tropical Medicine. She's also part on the Rebuild for Resilience project, where she co-chairs the Gender Equity and Justice Working Group. So I think she's very much set up to give this talk. Before joining the work in Liverpool, she was also working as a pediatrician in Cairo. So, Wissam, could you take us through the central concept for this session and introduce the health justice?
Wissam, you're muted.
Sorry. Okay, sorry about that. Thanks, Egbert. Hello, everyone. In this presentation, I will try to clarify the concept of health justice in health policy and system research. So our basic knowledge about health justice is that we have equal distribution of health resources, equal access to a quality of healthcare, and fair health outcomes for all populations. However, in reality, this is hard to be achieved, and specifically in fragile and conflict-affected settings, there are a number of factors that hinder health justice due to the inefficiency of the system, due to corruption or weak institutional and administrative structures that might lead to unavailability of the health services, poor quality, and poor access to care. Unfortunately, there is gap in evidence, and health justice is not explicitly defined in health policy and system research, with lack of empirical data on what is really meant by health justice and how it can be used or applied in health systems research. Next, please. Therefore, in Rebuild for Resilience, we were keen to explore the concept of health justice. And in Rebuild, we have the Gender Equity and Justice Working Group that works to ensure mainstreaming of these concepts in all Rebuild activities. So together with the early career researchers working group, we conducted a rapid literature review with an overall aim is to understand the concept of health justice and explore how it can be used in health systems research. We reviewed 40 articles, and among them were only 6 articles from low and middle income countries and only 5 empirical studies. And this demonstrates that we do lack evidence on health justice application in different contexts, and that we are more on the theoretical side. However, this literature review helped us to define health justice and learn more about its theories. Next, please. So what is health justice? We found that health justice is an emerging framework that requires the use of policies and laws to frame healthcare as a human right, ensure dignity and fairness to everyone. It also stresses the social determinants of health and how we can address any challenges or underlying socioeconomic and political factors that lead to health injustice. It's also calling for equity in the public health system, supporting the provision of equitable and quality of care, and ultimately contributing to the achievements of universal health coverage. Next, please. In fact, this shows that health justice really goes beyond acknowledging equities and to have a more equitable, just system and free of discrimination. But this needs a number of strategies to support the promotion of health justice or fostering health justice. These include policy reforms that integrate health justice in health policies, advocacy and social movements that call for health justice, community engagements, participatory research, and again, addressing all social determinants of health. Next, please. In our findings, we also found that health justice is explained through a number of theories or linked to a number of concepts. Next, please. So the first one was the right to health, and by this, we found that health justice is explained as an extension to the right to health approach, and by that, it's embedded in the framework of human rights and social inclusion. The right to health imposes obligations on governments that encompasses a range of principles as shown in this diagram. So basically, governments need to strengthen the accountability mechanisms, make health services available and accessible to everyone, foster participation of all key stakeholders, including the community, and fostering non-discrimination at the center to provide quality health care. Next, please. Another theory links health justice to intersectionality. So health justice is embedded in systemic factors, including policy decisions, governance structures, financing mechanisms, several service delivery models that all integrate health justice or promote health justice. However, these systemic factors are influenced by three main domains that could lead to health injustice, and these are the economic maldistribution, cultural malrecognition, so health justice is not situated in the historical and social conditions of a certain community, and political misrepresentations where policy decisions do not integrate health justice. And all of these can be shaped by the neoliberal capitalism, racism, and patriarchy. And by these, we need that health justice need an integrated intersectional approach where we can bring together all these three dimensions to address health injustice. Next, please. Then we found also that health justice can be explained through the capability approach explained by Venkatapuram theory of justice. Venkatapuram argues that health is not only the absence of illness, but it's a fundamental capability that enable individuals to have the necessary opportunities and resources to attain good health. It's also linked to other capabilities such as education and social inclusion and so on. He also highlighted the importance of the context, including the available resources and its distribution, the existing health actors and their relationships, and competing interests among each other. And in fact, protracted conflicts provide an example of how health justice can be explained through the capability approach. We can see how conflicts erode the capability of citizens to lead healthy and safe life, and the capability of governments to be able to support their health systems and their populations. Next, please. Finally, health justice and power, and by this we mean that health justice is also a movement of power building and transformative change to eliminate health inequities. And this requires a redistribution of power to change the current situation. So we need to build the power among those who are most affected by health inequity and breaking the power of interests that undermine health equity. And this needs to strengthen the political capacity of people who are disproportionately affected by health injustice through these three reinforcing mechanisms. So we have community organizations, community engagements, coalition, and development of social movements and advocacy that call for health justice, and strategic institutional negotiation also that support health justice. Next, please. So in conclusion, our literature review shows that health justice goes beyond health equity, trying to address the underlying factors that lead to unequal health outcomes. However, we are still on the theoretical side, and more empirical evidence is needed, specifically in fragile and conflict-affected settings that experience different forms of health injustice exacerbated by the unfavorable political and economic situations. Finally, to promote health justice, we need to incorporate analysis of power, participatory approaches in health systems research, working closely with communities, especially the marginalized and the most vulnerable populations, engaging all key stakeholders, and intersectoral collaboration to develop health policies that integrate and promote for health justice. Thank you.
Thank you. Thank you very much, Wissam, for this excellent talk and brief overview of your literature review, introducing health injustice, health justice. As you say, it's largely a theoretical framework, and I think if you hear it, we all sign up for it. But I think always the challenge with this kind of concepts comes of how could you work on it? What can you do with it at field level? And in particular, as you say, in fragile and conflict-affected settings. So I'm sure this will never be the last thing we want to say about health justice. It's a kind of an emerging field still, and I hope it will be helpful to guide our work. But let's try to look at some concrete examples on the ground where there is gross health injustice, and in particular fueled by some of the conflicts we have in these countries, but we see many conflicts in the world these days where similar things do happen. Before giving the floor to the next speaker, just a brief housekeeping thing to Farid. Could you give me access to the Q&A box, please? So please, Karen, could you show the next slide? Yes, I would like to introduce Professor Laila Al-Somboli, who is here listed as the head of the pediatric department at Al Sabin Hospital for Maternity and Children in Sana'a in Yemen. Unfortunately, she is not able to join us today, but she kindly prepared this talk, so we have it on video.
Today I would like to talk to you about how will be the health system in a situation of war or fragility situation. As you know, Yemen was under war and siege for about 10 years ago, since 2014 till now. When we talk about the effect of war and siege on a health system, I can take it from 2 points of view. First of all, about the capacity of the health system on face of the demand for the health system. So if we talk about the capability and the ability of the health system, we found that it affected too much. For example, from the point of the buildings, there is a lot of destructions due to the airstrike on the Ministry of Health, on the hospitals, on some of the health centers, etc. So there is destruction in the building itself. Then if we look to the health system as a health system as an infrastructure, usually any health system introduce a lot of services, so most of these services was affected, and at some point they are stopped at all. For example, the Ministry of Health cannot give any budget to the hospitals to work, so there is no salaries, no budget for the hospitals to work. There is inavailability of the fuel that led most of the health facilities to stop from working for some times, and sometimes limited their work. Also, there's no maintenance for the equipment inside the hospitals. Most of them are now so old, not working. From the side of the primary health care as one of the services of the Ministry of Health or the health system, there is a lot of defect. For example, regarding the vaccination, at the beginning the government cannot introduce the vaccine because of lack of the fuel, because of the siege. The roads are cut, there is not the traffic is so difficult to distribute the vaccines if it arrived, and this has created a big problem. People refuse to vaccinate because they are not sure about the validity of these vaccines, where the storage is not proper, there's no fuel, the journey to reach them is so long because the roads are cut. So this is a problem. Also, there is a lot of programs stopped from working because no budget, like some infectious tracing of some infectious diseases, etc. The training, the sector of training the doctors also, because there is no budget, is stopped. So doctors or health workers cannot find any updated courses or training or increasing the staff by training them. There is no budget for it. There is a big shortage of the medications. Most of the original companies withdraw their services from Yemen because of war. So the drugs that found in the market is only not that quality, and some of them also entered to the country illegally because I told you everything is so expensive. The airport was closed. The port was also closed, so companies cannot find an easy way to bring in the drugs. So some businessmen introduced illegal drugs, and it happened that we have some leukemic patients died from this type of drugs. A lot of our patients suffering because of the lack of the drug, like the chemotherapy for cancer patients and dialysis solutions for patients with renal failure. There is no immunoglobulin, there is no albumin. You know, a lot of these expensive drugs there isn't at all. So, and the Ministry of Health cannot bring them in to the country because of the financial resources are so limited. The cadre, there is a big problem with it, as many of them, because there is no salary, no any financial support, they left either to another places inside Yemen, or they are fly out of Yemen, try to find their any good work outside. So we left in the hospitals with very few health workers and doctors, and also with sometimes with unqualified personnel who try to fill out the gap of those well-trained nurses or very good doctors. So we started to depend on some junior doctors or some not well qualified nurses. So in front of all these defects, there is a big demand. As for example, in Sana'a, the population was only 2 million before war, but because of the internal displacement, people fly away and run away from the hot areas of war to Sana'a, and now there is like 4 million person. So there is a more demand for health services. Those displaced people are living in camps, and this has created sanitary conditions where no latrines, no clean water, and no vaccines, and no health education. So all these factors led to spread of a lot of epidemics, like cholera epidemic, diphtheria, measles, whooping cough, corona. Mass epidemics led to the more increase to the need for more support from the health system that already collapsing. So this is make also another problem for the health system. So the situation is so horrible, and we wish in one day this war finish and everything go back to the previous time. Thanks.
Okay, well, we wish we could thank Professor Nelia in person, but we'll definitely pass it on. I think it was a very excellent impression of all the poor things what happened in Yemen. And so let's move on to another country which is more recent in the news of a lot of horrible things happening there. So we are very keen to hear an update and see what happens, and if you can address health justice at all in the country at the moment, or that certain conditions need to be met before. So we're very happy to have Dr. Mohammed Abdul Ghadir today with us. He is Chief of Party of the project Momentum Integrated Health Resilience in Sudan. And he will take us through some of the work they are doing in the Sudan. And so please go ahead, Dr. Mohammed.
Thank you very much. Hello, everyone. My name is Mohammed Abdul Qadir. I'll present a study from the Momentum Integrated Health Resilience in Sudan. Next slide, please.
Yeah.
Yeah, Sudan context. In April 2023, violent conflict erupted between the Sudanese armed forces, SAF, and the rebel support forces, with the state of the economy already precarious, exacerbated by the social unrest, shortage of basic service and livelihoods inputs, and freezing of foreign assistance. The military conflict has reactivated prior fault lines in different parts of the country and risks pushing the country into a state of collapse. Impact of this, over 16,532 fatalities, including thousands of children. Massive displacement out of the pre-conflict population of 45 million people, almost 9 million people have been forced to leave their homes, with over 6.8 million displaced within Sudan, including 1.6 million women and girls of reproductive age. Imminent famine and acute malnutrition. Almost one-third of population is facing severe food insecurity, including almost 1 million children expected to suffer from severe acute malnutrition. Although the needs are huge, the humanitarian access has been severely embedded. So here, what I want to mention about the health system is already collapsed and disease surge. Like almost 80% of the health facility in conflict affected states or districts are no longer functional. And around 65% of the total population lack access to the health services, including pregnant women and young mothers. And the outbreak of cholera, almost 11,000 people since September are suffering from the risk of cholera and other forms of outbreaks. And 4 million women and girls at risk of gender-based violence with limited access to the services. With high burden of non-communicable diseases that reach above 51% mortality. And 62% or 62 recorded attacks to the health staff resulted in 38 deaths of the health workers and 55 injuries. And also the humanitarian workers, 45 humanitarian workers have been killed since the start of the war. The UNHCR aims to increase the capacity of Sudanese institutions to sustain, to sustainably plan and manage and maintain quality maternal, neonatal health, child health, and launch services. UNHCR will achieve this through improve access to and use of quality services and strengthening the capacity of the Sudanese institution at the facility and community levels to deliver MSH, maternal, neonatal, child health, and wash services that focus in one state, as we see from the map, South Kordofan. Since October 2021, the UNHCR supported 15 health facilities, including 3 hospitals and 12 primary health care centers in 3 districts in South Kordofan, reaching an estimated total population of 213,315. Technical priority area are maternal, newborn, child health, and water, sanitation, and hygiene. Next slide, please. UNHCR partner with Midwife Association to provide supportive supervision and clinical mentoring to the midwives in the catchment area of the 15 health facilities in the 3 districts, Dalanj, Karugli, and Habila. UNHCR is also supporting with the association to strengthen their internal administrative, financial, and HR system to ensure their longer-term viability as an organization. UNHCR partnering with the association began 8 months before the conflict started in Sudan. because they have, and that has helped IMCR to continue programming in the South Kordofan. The conflict disrupted, but did not stop the association, the Midwife Association, from continuing its activities because they have a presence in the three districts and they switched from private to public transportation to reduce security risk, and that enabled them to access the site while during the conflict. In response to the armed conflict and displacement, the association shifted the location of its activity to the communities from the health facilities to better meet the needs of women, including the IDPs. On average, the association mentors 91 midwives per quarter. An IMCR partnership with the association support the social cohesion and trust in the health system because the association is politically neutral, local institution, and the decentralized, and so that they have access to the location that other actors cannot reach. Members have continued to serve their communities on the front lines throughout the crisis, even when they themselves have been displaced. Next slide, please. Second rider. AMISA is implementing community-led solution for increasing access to safe drinking water. Circuit rider are community volunteers who routinely inspect, maintain, and repair public water points in the community surrounding by AMISA-supported health facility. AMISA provides training, spare part, tuk-tuk, and operational cost and ongoing technical support to those community-led teams. AMISA implemented this model plan for 3 districts in South Kordofan, but currently, as you can see from this map, the community managed preventive maintenance team, they managed to repair 23 water points in Kadugli district. The community-led solution contributes to social cohesion because it reduces the risk of the conflict over the scarce water resources, either between different ethnic groups or displaced and people and the host communities. Next slide, please. Like the key takeaway from AMISHA is promoting peace and health justice in armed conflict setting. AMISHA is strengthening the health system in armed conflict setting by strengthening the capacity of the non-governmental and non-political community-based institutions such as Midwife Association and the also community-led solutions like the secretariat team. AMISHA work at most decentralized level at the Midwife Association Secretariat to provide quality maternal and neonatal child health and water service to respond to the community increasing needs. Thank you.
Thank you very much, Dr. Mohammed, for this very insightful presentation on what happens and what you are still being able to apparently do even under the current dire conditions. And in particular, it's great to see that midwives can still continue by being organized and go into the communities rather than sit at more vulnerable health facilities as they are these days. So thank you very much. And I would like to call on our next speaker. That's Dr. Kain YYO. She is from Myanmar. She is currently the Deputy Chief of Party for Community Partners International. She has a wide experience in leading all kind of project, financial and grant managements in conflict affairs areas, in particular in the southeast of Myanmar. And currently she is with this organization, and she will take us to Myanmar and see what is possible there in those difficult circumstances as they are currently in place in Myanmar.
Good morning, afternoon, evening, everyone. Thanks for giving me the opportunity to be part of this webinar. I'm delighted to be part of the discussion of this critical situation around the world. So as Dr. Ebert introduced, my name is Dr. Kang Wee from Myanmar, also known as Burma, and I'm currently working as a Deputy Chief of Party for the Local Empowerment and Resilience Network called LAN, which is funded by the USAID. So my parent organization is the Community Partner Indonesia, is a US-based nonprofit organization. So today I would like to present the healthcare situation in Myanmar in a conflict setting based on my 12 years of experience working with the ethnic service provider in the conflict-affected area. So before I share my experience, I would like to present briefly our country profile and the political landscape, which are really important in terms of health justice. Next slide, please. Okay, so my country, Myanmar, has a rich history and complex political landscape. So Myanmar, formerly known as Burma, holds a strategic position in the Southeast Asia, bordered by India, Bangladesh, China, Laos, and Thailand. As of the latest census in 2014, Myanmar has a population of around 50 million people, and out of this, about 70% reside in the rural area. So this rural demographic influenced the country's socioeconomic structure, as the agriculture playing a major role in its people's livelihood. Turning to the political landscape, Myanmar gained independence from Britain in 1948. However, the journey since independence has been a testament to the resilience of our people. So the country post-independence history marked by unrest and the conflict, it's been a constant struggle for the ethnic and the sub-national autonomy. From 1962 to 2011, Myanmar was under military rule. So this period was marked by significant repression and isolation from the international community. Between 2011 and 2013, the country experienced quasi-civilian government terms, which provide a hope for political reform. So this hope seemed to materialize further with the civilian-led democratic government from 2014 to 2020, making a significant step toward the progress. But sadly, this progress was suddenly interrupted by the military coup in February 2021, bringing the country back into the political instability. Next slide, please. Allow me to share you about the healthcare system in Myanmar. So the healthcare system in Myanmar is characterized by both public and the private sector, which playing a crucial role in providing health services in the population. So Myanmar public healthcare system is a centralized structure managed by the Ministry of Health, which is a government-affiliated body. So this system aims to provide healthcare services to the entire population, focusing on both curative and the preventive service. However, this health system cannot be accessible and acceptable by the population who reside in the hard-to-reach and the conflict-affected area. So on the other hand, the private healthcare sector in Myanmar is very diverse and include both formal and informal entities shown in the slide. So, and there are also non-government organization, NGO, CSO, and the faith-based organization who step in to fill the gap left by the public and private sector, especially in the underserved and the hard-to-reach area. So due to the long-standing civil war, the population in the ethnic region had faced unique challenges in accessing healthcare. So ethnic authority in these ethnic region have made great effort to provide the essential health services to their community. Health workers in this area are reaching out to the people in the remote mountainous area and the deep forest to provide the essential health services. So therefore, community-based ethnic health systems have demonstrated remarkable resilience for over 50 years. Next slide, please. So I want to share my observation on the crucial role of peace in the healthcare provision based on my experience working with these ethnic health providers for the conflict-affected population. So as I mentioned, during the civilian democratic government terms between 2014 and 2020, we make significant effort to bridge two different healthcare systems, which is the central government health system and the ethnic health system. So this initiative aimed to build the trust and the foster collaboration between the two entities under the motto of the health as a bridge for peace. So during this period, government body and the ethnic health organization embarked on collaborated journey aiming to converge their separate health system. So this initiative, we call like a healthcare convergence, not only improve the healthcare delivery, but also support the peace process by fostering coordination and the collaboration. So as a result of this initiative, we saw several positive developments such as joint immunization, which helped expand vaccine coverage to the children across different regions, and the patient referral system, which allow ethnic health facility to send the patient to government public health facility to get the advanced care. So these activities serve as a testament to the potential of the healthcare as a bridge for peace. However, these promising initiatives were abruptly stopped by the military coup in Bali 2021. Next slide, please. So apart from the disruption of the peace building effort after coup, you all might probably want to know what has happened at the healthcare sector after the military coup. So since the coup, member of the medical profession has been at the forefront of the anti-military protests and the national strike of the public worker known as the Civil Disobedience Movement, we call CDM. So this brave health worker has stood up against the military regime, advocating for democracy and the human rights. So in retaliation, the military has taken several measures against them. So this has forced many CDM health workers to seek refuge in the ethnic control area, where they continue to provide healthcare services to the best of their ability despite the difficult circumstances. So in this ethnic region, we are witnessing the emerging of the jungle hospital or the makeshift health facility in the ethnic control area. So these medical centers are the testament to the resilience and the dedication of our healthcare professionals who are determined to continue their mission of saving life, even in the most challenging environment. Next slide, please. However, this effort has not gone unchallenged. So the military has targeted this facility, launching airstrike, and that have resulted in significant damage. So according to the data from the Insecurity Insight, there has been a total around 1,100 incidents of violence against healthcare in Myanmar. Since then, at least around 900 health workers has been detained. So in the ethnic control area where many CDM health workers have sought refuge, health facility has been set up in the jungle, and these health facility have become target for the military airstrike. So according to the data from the Insecurity Insight, the airstrike attack against the healthcare facility has increased year by year starting from 2021. So a report from the Myanmar Witness also highlighted the military targeting of the healthcare facility in the ethnic area constitute a violation of human rights and the international humanitarian law. Next slide, please. So despite of the several difficulty, health workers and the community show incredible resilience and the determination to establish a robust healthcare system. So in ethnic area of Myanmar, ethnic leaders are now preparing to set up the federal health system. So following the military coup, many health workers sought refuge in this region, and their influx significantly strengthen the local healthcare workforce and allowing for the expansion in the service provision from primary healthcare to secondary and the tertiary healthcare services. So to frame this discussion, I would like to reference the WHO Health System Resiliency Framework and reflect on our current situation. So after coup, the ethnic leaders from the ethnic region recognize their capacity and the influx of the health worker in their area. So this recognition has been crucial in mobilizing and coordinating available resources to provide the essential community health services and also upgrading the healthcare provision. So ethnic leaders have effectively mobilized and coordinated resources to maximize their impact. They have also established the connection with the international community and the neighboring country to secure essential medical supplies and the support. Beyond providing the essential health services, ethnic leaders also striving to expand preventive care, vaccine program, and the epidemic control measure for the infectious disease. And ethnic leaders also committed to providing inclusive and diverse health services to ensure that all community members reside in their area, regardless of their background, can access the necessary healthcare services. So this approach promotes equity and strengthens the community trust in the health system. So in the face of the conflict, ethnic leaders constantly learn and adapt their strategy to improve the service delivery. So they are committed to applying lesson learned to enhance their response to ongoing and the future challenges. So this adaptability is also a vital component of the resilience of the health system. So this is my personal reflection based on the current situation in the ethnic area related to the healthcare resiliency of our people. So this is the end of my presentation, and thanks for your kind attention. Thank you.
Thank you very much, Dr. Kind YYO. Again, another great presentation from different part of the world, different conditions, different opportunities to approach people again, and it strikes again that all those circumstances are so different, and nevertheless we want to draw some lessons which are maybe more applicable for also for other sessions, as is already visible in our Q&A box where they ask some of those questions. So for any participant who would like to raise a question, I'm sure there's still a bit of place to ask questions. Please do so in the Q&A box, and we will try to allocate the question to the most appropriate speaker or presenter. But first, I would like to give the word to our panel members, which are Dr. Fouad and Dr. Mohammed Al-Khadi. Dr. Al-Khadi is an assistant professor at the Canadian University in Dubai and a scientific lead from which, unfortunately, I don't know the acronym TGHN in the Middle East network at the University of Oxford. And I'm sure on the next slide we have Dr. Fouad. Yes, indeed. He recently joined the Liverpool School of Tropical Medicine. Before that, he used to be at the American University in Beirut, himself being from Syria, and working on a great number of issues concerning health systems in difficult environments. So I would like to ask both of you, could you, having heard the presentation, the more theoretical framework of health justice, as we heard initially from Wissam, and thereafter the 3 case studies from 3 very different contexts. Do you see any commonalities? Do you see any differences? Did you come to any lessons which could potentially be drawn from these case studies and the link with health injustice or justice? So please let me give Dr. Al-Khadi the first floor because your slide became first. So
yeah, thank you so much. Thank you, Egbert, for having me, and thanks for organizing this important event that actually addressing very burning topic. And yeah, as we can see that we have around 45 active conflicts in our region, and of course we have some commonalities reported in the 3 case studies presented. One of these commonalities are the context-specific related issues that actually focus on the capacity building and integrating the social justice and security within the healthcare systems, structure and interventions. And the second point is the community participation, or the non-governmental institutions. They have a key role, and they actually participating and contributing to alongside with the Minister of Health or other healthcare providers. And also some cases are, really integratively and structurally considering the health as a human rights or a fundamental principles that actually integrated within the social construct and paradigms that actually shaping the healthcare systems, considering the principles, the values, and also the approaches of the human rights with a focus on the health. And the last commonality is, there is kind of a governance structure in a place, but I think these structures or the governance structure are still needs to be upgraded, advanced, to be expanded, to have like all stakeholders involved, representatives, and also the decision making that need to be linked with this updated or promoted or reformulated structure of the governance, to have all people, stakeholders, and representatives involved in the decision making process. As the conflicts are touching a very national important needs and the priorities, and you need to actually have all people and the stakeholders involved in the process of the decision making and the community participations alongside with the decision makers and policy makers in each context. So there are many differences and limitations. I think we can actually cover it in the second interventions. Over to you.
I think, yeah, thank you very much, Dr. Al-Khali, for these comments and these three different commonalities that you have been identifying. Dr. Fuad, do you have any perspective on what we've been hearing?
Well, first, thank you, Egbert, and thanks for the speakers and for the organizers. Well, I mean, to be honest, I start thinking from the beginning about the title, so no health without peace. And it's like something that I like it because, in many, in the literature before, we start thinking about health as a bridge to peace, which start with health to go to the peace. Here, we have like a more focus on, health is not a sort of applicable process without having like a sort of a sort of peace. I would, listening to the three case studies, and in mind many other case studies in the region and beyond, thinking about how health is a very political issue, and this is something that for a long time we as public health people, they didn't take it sort of seriously. We always rightly advocate for neutrality, impartiality, impunity, and all these issues. But, the reality that, health is a political issue. And that leads me actually to when thinking about, well, how to address that in armed conflict, how to address healthcare in armed conflict when the actors, or saying like decision makers, are multiple and are not actually on the same, sort of ideological, let's say, front. And that's the issue. I mean, for me, issue.
You're breaking up, I think. Dr. Fuad, yes. Dr. Fuad, you're breaking up, so we missed the last minute of your talk.
I'm sorry for that. I mean, I'll back to the issue of who makes decision in health decision in armed conflict. And this is the issue. I mean, thinking about the three case studies, is it like the local communities, the government, and but government actually is part of the conflict and not like a neutral body. And that leads also to the issue of the role of international entities. And I would bring back to this principle of responsibility to protect. And it seems that we need to think about this issue of responsibility and therefore accountability, in a more effective way. I'm thinking of this issue of attacking health facilities that turned to become a strategy now in many of the conflicts. Health or healthcare is a weapon against people, and unfortunately, in many cases that even post-conflict or long post-conflict transition time, there wasn't any sort of accountability. And that actually led to, in more recent conflict, that still the strategy is on. So the question that I would come back later in the conversation, well, who is responsible, to address health needs when we are in such a sort of protracted long-term conflict and instability? And is it like the local communities? And well, how that could be done? Is there a role for government? Well, which government when talking about limited statehood areas? Is it the global entities? Well, what's the strategy? How to active, the issue of implementing the international humanitarian law? I think, in the last 2 decades, the issue of addressing healthcare and health system in protracted crises open doors to a lot of new questions that we need to engage or involve in answering that with a new paradigm of thinking about, health system in fragile and armed conflict settings. I will stop here, and hopefully I can come back to few suggestions about, what to do. Thank you.
Well, great. I think you raised a great number of very important points, and we have only a few minutes left. So I definitely feel we only start scratching a bit of surface in this webinar, and it definitely needs a follow up to go into much more depth. That's already one lesson I'm drawing from today. In particular, this issue of accountability that seems to keep coming back in so many different angles, and that's largely unanswered. And who is making decisions, and also within government, who is making decisions? That's another thing which often gets they're often not one whole. Let me first take a look before coming back to both of you and give you the second round you both asked for, and you will definitely get it. But let's briefly look at our Q&A box. We have a few questions there. One is answered, but even two are answered by Wissam. But I'm not sure if people can see both the questions and the answers. So maybe, Wissam, you have started to respond to one or two questions. Could you maybe get back to them and briefly explain what you have been writing, and also explain the question which was there initially from Halima to Kamara?
Okay, one question was about what strategies worked in our research to enhance stakeholder participation in health system. And I replied that we need to first have a stakeholder mapping and analysis. This is really important to identify our key stakeholders, identify their needs, and work to address these needs. If we manage to do that, we will get their initial support and engagements, and then we can develop kind of a communication channel to make sure that there is a mutual communication and active feedback loop, and we can always bring them together to participate in the decision making, in the planning and the implementation processes, as explained by Dr. El Khaldi and Dr. Fuad. And by this, we are enhancing their sense of ownership and their engagements. And very important, we need to manage their expectations so we don't get them frustrated or upset in the middle of kind of intervention or something. And by that, we can ensure their continuous support and engagements throughout the process. Thank you.
Okay, thank you. What I'm also seeing, there was one direct contact established between one of the participants and Dr. Chaim, asking for some more information. That's perfectly well, that's been answered. But if any of you would have any questions even later on, please approach us. There will be an email address where you can ask additional questions, which you may have, in fact, after the session, because I think there's so much material which you have to go through. What I then see is a question from Tabitha Herinik, if I pronounce it correctly. And she said, I'm curious if any presenters or panelists have comments on whether you have observed groups or populations losing trust in health services or health workers, local and or international, due to perceiving them as being allied with political movements or armed groups. And I did see an answer from Dr. Abdul Kadir. Maybe, Dr. Abdul Kadir, could you maybe present that answer so that all participants know about it, about mistrust in warring parties?
Thank you. Actually, we have not seen any report of mistrust between communities, local communities, on the humanitarian actors or the health provider, but we have seen the warring parties. They are like mistrust the humanitarian providers sometimes, and that also led to the closing the humanitarian corridors and putting like bureaucratic administrative impediment for the humanitarian access. But the mistrust is on the warring parties, not the local communities. Although there is no evidence showing that the humanitarian actors or the health providers, they are using their facility or the supply routes to support or stand by one of the warring parties. They remain neutral in all locations, but still we have seen the mistrust on the warring parties, not the local communities. The local communities are welcomed and they receive all the support, and there is no report showing that they are mistrusting of any of the humanitarian actors. That's the good thing to mention. The humanitarian actors, they remain neutral in Sudan in all parts of the country.
Thank you for that answer. In the meantime, I'm looking at some of the other questions. There is a very broad question from Shahinaz Nigeria, asking what specific strategies have you found to be most effective in delivering care under these conditions? So that's a comment to for us, those of us who are working on health justice in contract settings. I guess the question is probably a bit too broad to answer now. You've seen glimpses of it. I think Dr. Khain, in her Myanmar presentation, she gave kind of a general approach. Also, the two panelists have alluded to this. I think that should be answered. But maybe I would like to read your other question, which you have, and I was wondering who would be best placed to answer this. But it reads that the Palestinian people have a strong sense of resilience. As we all know, physical resilience is not the same as psychological resilience. Would it be possible to restore short-term health and well-being in Gaza, and how? I don't know if someone feels the impetus to answer this question. It's obviously a very important question, seeing the current situation. Also a difficult question to answer, I'm sure.
Can I try?
Yes, please. Yeah.
Well, yeah, you're right. Definitely, this is very difficult question. But I think the answer is the second comment by Shahnaz, when she put a quote from Rita Jakaman about any discussion of resilience without talking about social justice and liberation could be a sort of illusion. And I guess that to some extent this is something important to think about. All these limited health initiatives within conflict, within very brutal conflict, whether we see now in Gaza or we saw in different parts of the world, are definitely very appreciated to do so. But that's not enough. I mean, there are many routes for this issue, and that actually means for us as a public health people to engage more and more in the root causes of that. And we cannot stop saying that, well, we're neutral and we cannot engage. We need to engage in the also very hard discussion about the role of oppressors, the role of, dictators, the role of, I mean, that's sometimes the non-state actors. So I think this is important. We need to consider that, in our research. And I read it somewhere, which is also rightly, that there is a huge room, and I think Wissam mentioned in the beginning about health justice. That's only few empirical research on that. So I think this is a huge gap in our approach, and we need to have sort of multidiscipline, intersectoral approach when trying to address health needs. And I mean, we need to bring the politics, we need to bring the legality, we need to bring the international law to our discussion and do more and more research to see what could be the right approach. And I will finish with the issue of, again, the role of international entities, the role of WHO, UN agencies, including UNICEF, the role of a giant organization, okay, MSF, Save the Children, and all those issues. So are the role only to address the consequences, the results of that, or that should be engaged in the pre-conference and pre-conflict to mitigate the issue of the consequences, and on the top, how to do accountability. And I'll bring it again because I feel this is on something that's very important to do. Over.
Thank you, Dr. Fouad. Very important remarks. I think we definitely have to build on this. Just
Can I give
for
a
information.
comment on that?
Yeah.
Well, for the Gaza case, actually, what's happening there is kind of, it's beyond conflicts. It's beyond, the, emergency situation. It's a genocidal attack or aggression that actually destroying the pillars of the society. And we saw actually, and still seeing, the systematic destruction, intentional destruction of the whole health systems and facilities, and also targeting the health professionals and workforces. In addition to targeting, destroying the social systems, financial systems, the infrastructure, etc. So what is actually important here, that this is the failure of the Global Health Organization that actually ignored the root causes of the problems, not only in Palestine, but also in other settings or cases, that they are dealing reactively with the issue, with the problem, with the emergency, rather than proactively. And I think the WHO needs to be actually playing a global health diplomacy and more political, I mean, away from the ideologies, but more equitable political role in actually seeking, or at least translating, the health peace initiatives that they actually developed, and working with the member states and also with the influential partners in each country that actually experiencing kind of catastrophes or crises. Also, we saw the global health organizations just documenting, observing, making statements, very powerful speeches, but on the reality, the situation it's fastly and rapidly deteriorating, with large number of destruction and damage, large number of deaths, injuries, and also kind of systematic destruction of the whole society. And we still hearing kind of statements, reports, speeches, and kind of international calls without any actual and serious changes on the ground. So I think the global health community and family are really confronting one power, the occupying power, just facilitating to supply the sedation for the surgeries, or for the major surgeries for the injured cases. So this is actually the simple case or simple example that actually clearly indicating that the global health actors, and the role is filled in the Gaza's case and in the other humanitarian actions in Palestine.
Thank you for this comment. You raised again how to confront this kind of situation, which of course very intractable, and we are limited in our capacities and even in the totalities of our health system people, health workers all over the world in addressing this. But you also indicate that we cannot not do it, and that has been a long-standing dilemma on how active she should be. But it seems these days it's coming so much to the forefront that we must be more active. But how to in fact do this, how to do this effectively, that remains a major question. What I would like to do is, because we have reached the end of our session, I think Dr. Swart, who had still said he would come back to us with another comment on things, how to do things. So I don't know if you have a final word, Dr. Swart.
Yeah, I mean, just to stress again about the role of international entities working on health systems and healthcare. I think we need to restore the role of WHO, other UN agencies, international organization as an active role in building peace and mitigating the results of war. And the last one is about the principle of responsibility to protect, which is something that is needed, during wartime and post-war time. Thank you.
Thank you very much. Yeah, as I already felt from the very start of our webinar, and it only gets worse and worse as we go. I think we do touch a topic which is huge, and we have scratched the surface, and it definitely needs to follow up. We start embedding this in our research, as was kind of clear also from the first presentation. But then what can you do in the field? How can all the responsibles in the health fields act better, and not only in providing some mitigation, but also working much more on prevention, as should be part of our health work. Well, I will present a few follow-ups, which we already have. This presentation has been recorded. It will be made available as soon as possible. You probably get a message from those who signed up. As it says, the recording will be available soon. We also encourage you to have any question you still may have or any comment. Please get back to us and pose those questions. We may also provide a brief blog about this session, which we'll post on the various websites and social media. Again, that might be some follow-up. In terms of the research, I think we are part of HSG, as you see, Health Systems Global. Below, and Health Systems Global is organizing every 2-year health systems conference. This year, at the end of this year, November, it will be in Nagasaki. Of course, that is dealing with health systems very much in general, but it will also be a part on more thinking about what to do in conflict. And it's a good forum to raise some attention of some of the issues we have been discussing this afternoon. So we look forward also to seeing some of you there, so that we also are able to organize maybe some side events to come back to this issue, in fact, which needs so much more longer term to discuss and consider. So I would like to thank in particular all the speakers for preparing their talks. In the short time that was available, you all have kept to your time. That's a bit unusual, so thank you very much that you all did. Thank you for the 2 panelists for the very useful comments, and also thank you for the questions being asked in the Q&A box. We have kind of touched on them, but again, there's so much more to be discussed. So, but for now, we need to finish. And thank you very much, and we hope at least to see some of you in future on other occasions to discuss more. Thank you.
Thank you. Thank you all. Thank you.